The blood culture pathway is essentially a relay race divided into three parts. Pre-analytical, collection of the correct volume of blood from the correct patient and getting that onto the blood culture analyzer in a minimum amount of time. The second part of the relay race is once that blood culture is received in the laboratory, is placing it on the analyzer, and then as soon as the blood culture bottle flags up positive, removing it and conducting the work to obtain the key result, which is essential to the management of the patient. Once this has been achieved, this now needs to be communicated to clinical teams so that they can modify antibiotic therapy to ensure either the patient is on the right treatment or de-escalate to a narrow spectrum treatment so that we can prolong the use of antibiotics now we're coming to the end of the antibiotic era. National audits have shown there is significant avoidable delays which can be occurred in a non-optimized blood culture pathway, and these are measured in days. A comparison was undertaken between an optimized blood culture pathway compared to a laboratory which had a partially optimized pathway. In the optimized pathway, 85% of blood cultures were complete, that is from collection to issuing of antibiotic sensitivities with an identification of a pathogen within 36 hours. In comparison to the laboratory which had partially optimized the pathway, to achieve the same results took more than 66 hours. One hospital recently optimized the blood culture pathway, and they did this by setting up a multidisciplinary group consisting of clinical staff, microbiology staff and blood science staff. And what they found was the clinical staff needed education. Nobody was actually aware that blood cultures were urgent specimens and should be sent to the laboratory without delay. Once this message was put out, then the turnaround time was improved. Blood science staff also had a significant part to play because they are present on site 24 hours a day, and they loaded the blood culture analyzer outside of working hours, so there was no delay. And actually they went one step further in actually starting the processing of positive blood cultures out of hours. But there are many ways to actually solve this problem. But the first thing is to actually audit, find out where you stand, and then set up a group to actually solve the problem. We've been given the most fantastic piece of equipment in blood culture analyzers, but we don't use it anywhere near its full potential. What limits us is our own biases and imaginations, and the technology exists. We can improve it and solve all the potential situations.
The urine dipstick will most likely be positive for nitrites, a chemical most bacteria make in the urine, and leukocyte esterase, which shows the presence of white blood cells. There may also be other markers, such as protein and glucose, which are unrelated to infection, but often present in older people. But none of these tell us whether or not there is actually a urinary tract infection. For this, a clinical assessment of signs and symptoms is needed, and the national best practice guidelines support this approach. But what's the harm in dipsticking? It is very difficult to ignore a positive result, even if it doesn't mean very much at all. It can be difficult to assess older people, for example if they are confused, and relying on the urine dipstick result in this setting may result in another diagnosis altogether being missed. It can also trigger antibiotics being prescribed.
To Dip or Not to Dip is a programme to improve the management of urinary tract infection in older people, particularly in care home settings. It reduces risk of harm to patients from unnecessary use of antibiotics and antibiotics that lead to a treatment failure when they do have a urinary tract infection. And this is because urinary tract infections are routinely diagnosed by the use of urine dipsticks, and this is not appropriate in older people. Older people are likely to have bacteria present in their urine but not have an infection. And diagnosis of UTI by a dipstick is not an appropriate way to diagnose a UTI. This means patients may often be prescribed antibiotics unnecessarily for a urinary tract infection that they don't actually have, and this puts them at risk of developing resistant organisms, and then this may result in a treatment failure when they do actually have a UTI in the future that does need treating with routine antibiotics. In addition, patients may be prescribed the wrong antibiotic because a urine dipstick test does not differentiate between a lower UTI, such as cystitis, compared to an upper UTI, such as pyelonephritis. To Dip or Not to Dip is an improvement bundle for healthcare workers that does three things: educates the workforce around antimicrobial resistance and why this matters so much for urinary tract infection, implements a consistent approach to diagnosing UTI in older people using a clinical assessment of the patient and then communicating that accurately to the clinicians involved in their care. And thirdly, improves the appropriate use of antibiotics within guidelines, reducing the risk of treatment failure. To Dip or Not to Dip has reduced inappropriate antibiotic prescribing by 66% in care home residents who were routinely diagnosed UTI by the use of urine dipsticks. In addition, it has increased the appropriate management of UTI, getting it right first time in older people and reducing their risk of harm.
Good morning, I'm Andrew McGinty. I'm a GP in Sheffield, a clinical director for NHS Sheffield CCG and chair of Sheffield's Antimicrobial Stewardship Group. I've been a GP for nearly 20 years, which has been long enough to see babies born into my practice become adults, and something seems to happen along the way. Parents who bring babies into the surgery who are relieved when the baby doesn't need antibiotics often become adults who are unwell, presenting with an expectation of getting antibiotics. Long I've wished for a test which will help me understand who needs antibiotics and who doesn't need antibiotics. Currently, point of care C-reactive protein testing is the closest we have to that. It's an acute phase protein which is raised when there's inflammation strongly associated with bacteria rather than with viruses. Nowadays, patients have greater access to information than ever before, helping aid their knowledge and understanding of their health issues. Being patient-centred means having shared decision-making aids such as point-of-care CRP testing means that they can be involved in understanding the issues that surround whether to prescribe antibiotics or not to prescribe antibiotics when they're ill. Through an accelerated learning event with the pilots and pioneers who are using CRP testing in the primary care setting, we've begun to understand some of the challenges that exist. It's not going to be for every patient with every acute illness in the primary care setting. The technology, despite being small, will have to be housed somewhere in a suitable environment, and it's a new cost to that part of the healthcare system, which will require an upstreamist approach to funding, as the rewards for using this technology may not appear for many years and may appear in other parts of the healthcare system. However, by working together through the Antimicrobial Resistance Collaborative, we can start to develop a policy which will ensure that the test is done in a clinically suitable and financially sustainable manner to help patients.